Acknowledge that we are hosting this webinar from within the ancestral, traditional, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. So thank you, those who are able to join us in real time today. And for those of us, have we recorded this? Excellent. For those of you that are joining in future by observing the recording, we also welcome you. So here with us today at the support unit, we have Dr. Hubert Wong, who is the lead of the Real World Clinical Trials Methods Cluster, and Heather Bartlett, who is with us from Project Management at the support unit. The intent of today's session is to give you a very brief update regarding the projects in round one of the Real World Clinical Trials Methods Cluster, and to introduce with the leads from two new proposed projects for round two. So without further ado, over to Hubert.
Thank you, Alison, and thank you everyone for joining. Down arrow. Down. Okay. Right. Okay. So the main part, the main goal of today's webinar is actually to discuss the potential round two projects. But I thought I would start off just with a summary of what's happened up till now, and so I think that will be useful for people who are new to this cluster. And I apologize to those for whom this is going to be a repeat. So the purpose of the Real World Clinical Trials Methods Cluster is to advance the methodology of real-world trials. And the question that people always ask is, well, what is a real-world trial? How does it differ from a regular clinical trial? And so there is a hard black and white rule that distinguishes one trial from the other. But in a regular clinical trial, the traditional one, their characteristics of these sorts of trials are that they are done in very idealized settings. So maybe within a particular clinician's practice. It often involves a very narrow patient population, so there are very stringent inclusion-exclusion criteria. And there is very close monitoring of the participants during the study follow-up. So maybe they're being seen every week or month or something like that. And the main emphasis of the trial is to try to establish whether a particular intervention is clinically efficacious on one primary outcome. Okay. Now, there's been lots of concern expressed in literature in the past few years that maybe the results from these traditional clinical trials do not apply or do not generalize to the larger populations because of these limitations that are placed when the trial is done. And so the question is, if you were to take an intervention and put it into practice in the real world, how well does it work? And so in order to assess that, what you want to aim for is to include very broad patient populations, so minimize the number of inclusion-exclusion criteria. You want to see how well this intervention works when it's delivered in usual care settings, okay, and without extra supports from these, such as close monitoring and being delivered by people who are sort of experts in this intervention. Okay? And in the real world, patients value more than just clinical efficacy on one outcome. There are all sorts of things which patients may be interested in, and we would like to evaluate how patients perceive or value those outcomes. So that might be things like quality of life or convenience. And so, the last point, again, on this slide is just repeating that clinical trials are not inherently traditional or real world. There is actually a tool called the PRACY2 checklist, which allows you to sort of assess to what extent a trial is real world along a continuum. Okay? And the reason why we're interested in real-world trials in this cluster, in this methods cluster, is that historically, most of the methods that have been developed for clinical trials have assumed that we were doing a traditional clinical trial, but now we recognize that with the limitations that are imposed on us in the real world, we need to improve those methods to make trials that are done in the real world more relevant, more efficient, and more robust. Okay. Now, on this slide is the first half of the sequence of events that were used in the development of this cluster. Okay, so at the very beginning, what we did was we held a bunch of calls for expressions of interest from the research community at large. Okay, there was a survey asking people to express their interest. We held one-on-one discussions with individuals who might be interested in this cluster. There was a planning event that brought together, I've forgotten exactly the number, about 40 participants from across the province, representing different stakeholder groups, so researchers, methodologists, healthcare providers, patient partners, and decision makers, to try to brainstorm what this cluster might accomplish. Okay. There was a post-event survey asking people to reflect on what had occurred at that planning event and to help us refine and ensure that we captured all the thoughts that were expressed during that event. And then there were follow-up webinars and discussions to engage people who were not able to attend that planning event. And based on all of that information, we developed some themes and specific projects that this cluster might undertake. Okay? And there is a web page that you can visit to look at what these themes and projects were. Once we identified the projects, we were asked the project leaders to contact people who were interested in being involved in that project and to come up with essentially about a 5 or 6 page proposal, okay, which was then reviewed internally within the support unit and then sent out for external review. And based on the reviews that came in, the unit decided whether or not to initiate those projects or to ask the project teams to go back and rework the proposals. Okay? And so at this point, there have been 3 projects that have commenced, and the support unit is providing ongoing support, monitoring, and evaluation of those projects. So the 3 projects that have been initiated are on this slide here. The first one is embedding patient values in randomized controlled trials. And the idea here is that, again, recognizing that patients value different outcomes differently, the question is, how can we figure out which intervention is actually best for that patient? Because different interventions will have different outcomes with respect to different aspects of patient values. The second project is in the development and evaluation of causal inference methods. Okay? And so the idea here is that in a trial, not all patients will adhere to their medication. And the question is, if we see or do not see a difference between treatments, is it because of some sort of bias that's been introduced by people not adhering to their medications? And so here we're trying to develop statistical methods to try and identify the impact of this non-adherence and to come up with sort of unbiased estimates of the true impact of intervention. And the third project is in increasing statistical efficiency of of real-world clinical trials. And that one involves the fact that historically, when we've planned trials, we've sort of made very simplifying assumptions, which often are not or do not reflect what happens in the real world. And so here again, it's a statistical project to try and figure out, well, how should we design trials in order to maximize their efficiency? Okay. And at the bottom, you'll see that there's a link that provides details on each of these projects.
Okay, so thank you, Dr. Wong. The main focus, as you've heard for today, is to hear from the leads of teams that have submitted proposals for consideration for round 2 projects in this cluster. So without further ado, I'd like to pass over to Dr. Anita Ho, who's going to describe their project proposal, which is about an ethical framework for ethical design and data integrity. So over to you, Dr. Ho.
Thanks, Allison. Can people hear me?
Yes. Yes.
I don't know if John Kramer is online. John, Kip, are you around? Okay, so I will just keep going, and then if one of my team members is here, then maybe they can also help to contribute as well. So my name is Anita Ho. I'm one of the associate professors at the Center for Applied Ethics in the School of Population and Public Health. And the project that we are proposing is to develop a framework on ethical design and data integrity for cluster trials. We do see that these two things are actually very much interrelated. And we are hoping that this will be helpful for researchers as well as research ethics as well. I'm one of the ethicists for the UBC Research Ethics Boards, and I'm very glad that Pia Gans is also online with us to help us develop this together. Part of the reason for thinking about this is that very often we think about research ethics in relation to consent, but that there are some more specific issues that come up when we're thinking about cluster trials. So next slide. So I'm one of the leads for this project. Dr. John Kramer, Kip, is one of our assistant professors in kinesiology and in the I-Court program. So we have been talking a bit about how do we think about real-world trials and clinical trials that may particularly, for example, for populations that may be smaller, and how do we make sure that the data that we're collecting from everybody would actually be captured and utilized, but in ethical kind of ways. So we have so far recruited Dr. Mike Burgess from our Okanagan campus, Dr. Catherine Banks, who is a nursing faculty member from Thompson Rivers University, Holly Longstaff, who is a privacy advisor for PHSA and also one of the members of our REB, as well as Stephanie Ling, who is a PhD student at the UBC Vancouver campus, who is also sitting on one of our REBs as well. We would certainly invite and welcome other people to participate as well. We're also currently in the process of recruiting patients who may be part of the research, as well as to be engaged with us on dissemination, knowledge translation activities. Next slide. So to give you a little bit of background, and Hubert and I have talked a little bit about this before as well, cluster research trials are now increasingly popular, particularly in areas of non-drug intervention studies. So this is very popular in population research, policy research, and service delivery interventions. Definitely very much of real-world trials that are often being done in the community and with various kinds of groups. These trials bring distinct ethical and data integrity challenges in comparison to other kinds of randomized controlled trials. In other trials, usually we're asking each individual research participant to consent, and they can also decline consent if they individually would not want to participate. So generally speaking, everyone would be signing a consent form. These people are the ones whose intervention is being used on in various kinds of ways, and we are also collecting the outcomes from these particular individuals. In cluster trials, it's a bit different. Very often, usually, we're using groups or clusters, and it may be a hospital ward, it may be a particular clinic, or we're comparing outcomes in various clinics, various medical practices, and so on. And so it's the clusters that are being randomized to intervention versus the control arm, rather than individual patients that may be randomly allocated. But also to add to that, the interventions may be delivered to various groups. So for example, you can imagine we're trying to find out whether hand washing is effective in preventing infection and so on and so forth. So the intervention about campaigns about hand washing may be delivered to healthcare providers, but the outcomes that we may be measuring are sometimes with another group, such as patients. So this really raises questions in terms of who actually are the participants in these studies, whose consent is necessary, is it at the cluster level, is it at the individual level, and what type of consent is necessary. For example, do we really need active consent for each individual patient, or do we just use implicit consent if nobody actively says, I don't want to be part of a trial? In some of these situations, the patients who may be part of these clusters may actually not be doing anything any different than the usual care anyway. So there may also be questions then in terms of how we think about the data in separating the data from those who are consenting actively and those who may not be consenting. How do we manage the data at the cluster level and at the individual level? So the question we want to think about is, how do we actually collect the data, manage the data, and use the data in a way that can optimize the balance of trust that the public may have in the research community, respect for individual autonomy, if that is relevant here. How do we promote also the data integrity and the pursuit of common good by engaging in research? The next slide. So the main issue that comes up from an ethical perspective is, generally speaking, the issue of consent. Very often, as I mentioned earlier, we want to make sure that everyone who is participating in a trial is providing consent. But in cluster trials, we often have this tricky question in terms of who are consenting or who are not consenting. The non-consenters, quote unquote, can be in at least 3 different categories. So one, there may be individuals who are actively saying that they do not want to participate. So they may be part of the medical practice. The patient says that they don't want to be part of this. So I want to just use an example that I'm part of. We have proposed to test a shared decision-making tool for heart failure patients. We want to see whether this particular shared decision-making tool that we have developed is actually effective in promoting more patient engagement in the medical consultation, and whether that actually leads to better decision-making process. So we can imagine, for example, even though that our clusters are individual cardiologists who are using the tools, but the cardiologists are using the tool with individual patients. So the cluster is at the cardiologist level, but the question would be, are individual patients also declining or consenting to be part of this trial? So we can imagine the non-consenters could be the patients who are actively saying that they do not want to be part of this trial. But you can also imagine there could be situations where the individuals haven't been given an opportunity to consent or refuse by the participating clusters. So it may be the case that the cardiologists assume that if they are consenting to participate, basically every patient who they care for would automatically be part of the cluster. And this may be especially those who are in the control arms. So the clinician may be thinking, I'm not doing anything differently, so I don't really need to actually ask patients to consent, because they are not actually using this specific shared decision-making tool with any of the patient. So these people may also be considered to be non-consenters. The third group of non-consenters may be individuals who have actually been excluded from participation, regardless of whether they have potential interest in it. It's possible that some cardiologists in a particular practice may say, I'm not interested in taking part of this, so then none of their patients would be even asked to consent or not consent. So the question that we may have in some of these situations is that there are actually many different types of non-consenters, but if we exclude the data from the very heterogeneous non-consenters, even when these CRTs may pose minimal or no harm at all to people in some of these clusters, then we may have issues about biased data. So this is where I think that the data integrity and ethical research come together. So even though we may think that at an individual level, that we are protecting individual autonomy and we're making sure they're not harmed by inadvertent or non-desired research participation, perhaps in some of these cases, biased data can lead to greater harm to the public. Next slide. So the research question that we have is, given that there are heterogeneous non-consenting individuals, what may be the ethical ways to collect and manage clinical data from these patients in the cluster trials that can, 1, preserve the public's trust in research enterprises, 2, respect people's rights regarding whether they want to participate in research or not, 3, ensure data integrity, and 4, promote responsive and responsible data utilization. Next slide. So what we are expecting and hoping to achieve in this is that we will be able to produce a framework that can guide researchers, quality improvement specialists, and research ethics board members on how to design, conduct, manage data, and review CRTs. We are hoping that after developing this framework, we can also, if budget and time allows, we can also develop an online module that can be used by different researchers and quality improvement specialists in thinking about how to design and conduct CRTs. Next slide. So we're thinking about 2 specific methods in this project. Right now, there is not a lot of literature written on ethical designs or CRTs, so we would like to do a scoping review of the literature that is out there, both academic literature and the gray literature, which may include some guidelines already on how to conduct and design CRTs. And then after having conducted a scoping review, then we would like to refine the research questions and conduct focus groups. We're thinking that we will be doing 2 phases of focus groups. In phase 1, we would like to conduct focus groups in British Columbia. We're hoping that depending on, in the end, our research team, we would like to conduct focus groups in Vancouver, Kamloops, and Kelowna with patient representatives, cluster trial researchers, and RAB members regarding their views on consent, privacy, and the use of data from quote-unquote non-consenters. So what generally we would like to see is, how do patients, for example, think about the issue of consent? Do they think that all consent is the same, or do they think that for certain types of trials, possibly including CRTs, that consent is not as important? Or do they want consent to be conducted in certain kinds of ways rather than other ways that may actually overwhelm them rather than inform them in relation to their participation? We also want to see what researchers' views are on consent, what they think would be the most important information that patients should know about these trials, the harms and benefits and so on, and how to communicate that. Then we would also like to interview RAB members who have been, of course, reviewing many different types of clinical trials to get their views on how they might differentiate different forms of consent for different types of trials, and the use of data from consenters and non-consenters alike. We would use this focus group data in combination with our result from the scoping review to inform the development of the framework. After we have drafted the framework, then we will conduct the phase 2 focus groups to evaluate the usability of this framework that we have developed, to see whether it actually addresses the questions that patients have, researchers have, and RAB members have, and then refine accordingly. Next slide. So as you will see the timeline, we're hoping to start the scoping review first before we conduct any kind of other empirical research. And then we will apply for REB approval to do recruitment for the phase 1 focus groups about 5 months after we start the project. And then we hope to then conduct the focus groups in September to December of 2019. And then the first 2 quarters, the last quarter and the first quarter of 2020, we'll conduct the data analysis and then start to develop our framework. And then we will, as I mentioned, conduct more focus group in evaluating this particular framework that we have developed and refine accordingly. And then we will like to perform dissemination and knowledge translation activities at the end of 2020 to the first quarter of 2021. So that's the main or the broad framework in terms of what we have been thinking about. And I would welcome any questions or suggestions as we move forward in including different representatives in our research team, and as well as any suggestions about methods as well.
So thank you very much, Dr. Ho. At this point, we actually have a good chunk of time before our next presenter is joining us. Dr. Huizi is going to be joining us at about 4 o'clock to present, as Dr. Ho has, the proposal for that project. So we'd like to open up the line right now to questions or comments on Dr. Ho's presentation. And Dr. Ho, as you mentioned, you have a colleague online. Would you like to invite that colleague to provide any further comments before we take questions?
I actually don't know if my colleague's online. Kip, are you online?
Okay, so maybe not then. So let's take questions. We really welcome, as you saw in the first couple of slides that Dr. Wong presented, the process here is that these project proposals go through an iterative process. It's not a typical competitive process. It is instead sharing these ideas as a community of methodologists and providing opportunities for others to either participate or to help shape in some way, provide ideas for the projects. So we invite comments now. Maybe we can pop back to the previous slide so that people can see maybe the 3 different levels of levels of consenters, and see if there's any questions about of non-consenters, and see if there's any questions about that. Cheryl, I know that this might be of particular interest to you or to you, Linda. So are there any comments on either on this slide, the issues of the 3 categories of non-consenters, or the proposed methods with the scoping review and the focus groups?
It's Linda. Can you hear me?
We can. Thank you, Linda.
Great. Anita, I really enjoyed the presentation, and congratulations on taking on this project. I think it's exciting, it's really important. I guess it's not a well-formulated question in my head, but you've mentioned that not a lot is known about this area, about the different levels of consent and how it sort of influence the kind of data that is being collected from cluster trials. So is there any I guess concern that as you're conducting the scoping review that would you be able to find anything in the scoping review?
Right. We would be able to find something because there is a quote-unquote Ottawa statement that has been developed by some of our colleagues in Ontario in terms of thinking about ethical conduct for cluster trials. Interestingly, I think that many of the suggestions that they have are very well, very sound and advice in terms of getting consent from participants and so on. But they haven't actually got too much in terms of what do we do or how do we actually think about who is or isn't consenting. So this is why we wanted to do a scoping review to see whether there may be other kinds of literature about research ethics when people talk about participants or people who may be in public health research, community health research, that may be looking more at, for example, participant observation and other kinds of research that individual consent is not always sought. So we want to see whether there may be some parallel considerations that we can think about that could be particularly applicable for cluster trials. But you're absolutely right that there isn't a lot of literature out there, but that's also why we think that we can contribute to the scholarly work out there.
And that is great. I am, really excited about, this line of questioning, and I look forward to your results. And as you and many of you know that, I work with the Knowledge Translation and Implementation Science Methods Cluster. So is there anything that we can help from the knowledge translation perspective? We'll be more than happy to talk about ways to work together and collaborate.
Thanks. And actually, one area that I think we might be able to get more support from too is outside of quote unquote research, is in terms of thinking about quality improvement, because very often the line between what counts as research and what counts as quality improvement is not as clear. And so sometimes actually some of these trials or things that people want to test at the bedside, we can think of them as research, and we can also think of them as quality improvement projects. And so very often in the community, there are projects being done that specific research consent is not being sought, but we are still using the data for various kinds of quality improvement purposes. And so we want to see how we might be able to think about cluster trials, or whether we should be thinking about cluster trials in some cases very similarly to quality improvement projects, and so that we can also, what we're thinking about can also be translated to quality improvement situations and vice versa.
That's great. No, perfect. And of course, the implementation science cluster randomized trial is something that is the methods being used in a lot of situations. So again, the contribution of your work, cut across methods clusters.
Okay, thank you, Linda. Linda, do you have any additional questions before we open up to others?
No, I'm good. Thank you.
Okay. Any other questions or comments? What are people's thoughts in regards to this type of methods question? We've put up again the research question.
Can I actually ask a question?
Most definitely.
Because I know that Pia is online. Pia works with the research ethics boards and so often have to deal with a lot of questions in relation to whether something qualifies as a research project that has to go through research ethics board review. So that I don't know, Pia, if you have anything to add in relation to sometimes maybe researchers' questions in relation to whether something counts.
Yes, we've seen a couple of these, and I think that researchers are looking at cluster trials a little bit more. The question around if somebody declines consent, so preserving the public's trust in research. So if they've said they don't want to consent, and they read data that was, collected, and that would erode trust. So we could maybe see a justification for a waiver of consent for the study in general. So it depends what's being collected and, you know, what the question is at the end of the day.
Okay, thank you.
Okay, let's, while others are formulating questions, Dr. Wong, comments.
Yeah, so I guess I'll start with the last one, which was about, you know, this getting waivers of consent and such, and it depending on the circumstances. I think that's part of what we're trying to explore in this project is, you know, under what conditions is it appropriate or ethical to ask for waivers of consent and when is it not? Because it seems to me that there aren't good guidelines about that at the moment. Do you agree, Pia, or?
Like I said, it depends on the research that's being done. We do see, you know, plenty of research where there's a justification. For example, BCCDC, they have a mandate, and a lot of the research that they do, they need like the whole, like everybody's data. For example, a new viral outbreak, where they have to collect all, you know, all the data on that particular, you know, public health incident. So yeah, we do see, you know, justification for waivers. So that'd be something, you know, we could look into, like what if other research ethics boards, you know, how have they grappled with that? I don't know if that helps.
Yeah, well, I mean, I guess you've given an example where it's quite clear that it's imperative to have that data. I guess the question is, when it gets into sort of a more gray area, where do you draw the line, or can you actually draw a line? The other related aspect about this is that does it sort of depend on what kind of data is being requested? So did you make a distinction between data that would be collected in routine clinical practice versus something that's being collected specifically for a study?
Yeah, we do. We look at those parameters. And I mean, like for cluster randomized trials, for the most part, they're huge. So it's not that an individual could, you know, have their personal information shared or, you know, confidentiality issues. So we just look at that. I mean, if you're looking at doing research in a small specific patient population, then there'd be more risk, you know, in terms of disclosure of personal information.
And it's interesting, especially when we have a smaller patient population in the first place, that any kind of exclusion of the data may make it even more difficult for us to think about how to use the rest of the data, because there is even a higher possibility of the skewed data. And so, and there may also be questions in terms of whether some people are less inclined to consent to participation because of the patient characteristics in the first place. And so that may also, in the end, affect the data integrity. But I think that going back to Hubert's question in terms of when we're waiving consent, what kind of data are we talking about? Because if we're thinking about cluster trials and the trials are actually being conducted when people are getting their usual care in the first place, we are collecting a lot of the routine data already. And so when I used the example about the shared decision-making study that we hope to conduct if we get the funding, if patients are saying no, what would that mean in terms of what we cannot collect, especially if they are in the control arm? Because basically all the data, all the clinical data would have been collected in the first place. And we were not generally collecting clinical data. We were really collecting other kinds of data specifically about their involvement in decision making. And so is it just that they don't do the surveys about decision making or how they do the decision making? Or is it that even the clinical data that would have been collected, whether they participated in that particular part or not, would still be excluded?
Anybody like to leverage the most recent comments? Maybe while we're waiting, Anita, I have a question. Given that the methods clusters here at the support unit and all the activities here at the support unit are primarily with a focus on patient-oriented research, how do you envision patient partner participation on this research team?
So that's why I was hoping that Kip would be on the call. So Kip Kramer is from the I-Cord program with people who have spinal cord injuries. And so they have been actually thinking about putting together or establishing a patient advisory committee in terms of research, partly because there are very few patients who are participating in research trials, and there are very few actually clinical trials in the first place for spinal cord patients. And so what he's hoping is that actually we can put both of these together and engage some of the patients who have been thinking about research methods and research participation, and that we can engage them in terms of thinking about what research participation means to them, what consent means to them, and what are their main concerns in consenting to or not consenting to participation. But I would be very happy if other people have ideas in terms of incorporating other patient representatives as well. We've been working with for the shared decision making project, Heart Life Foundation, some of the patients who are involved in clinical trials and for heart failure treatments. So we can also involve them in this as well. But one of the questions that I have is whether we think that we should engage patient representatives of a variety of conditions, or whether we think that we should be focusing on certain conditions. So Kip comes from spinal cord injury, but I think that we probably want the framework to be able to apply to much broader patient populations.
Yeah, I would agree with the latter point about ideally a tool that's applicable across various communities. Maybe as I continue here, Nader, I know that you're online and your work at the Blesson Center. Feel free to join in if you would like, but no pressure. But the element of helping to facilitate patient engagement as research partners on this project is something that is obviously integral to the work of the support unit, and I can assure you, Anita, as this project is developed and after review, that we can certainly assist you in supporting patient engagement on this project. Are there any additional questions? Stephanie, I see you're also online. From your perspective, working in the health economics and simulation modeling methods cluster, do you have any comments or questions in relation to your experience with cluster randomized trials and non-consent?
Can you hear me?
We can, Stephanie.
Okay, great. I think this is a fantastic proposal, very, very interesting. I'm definitely glad I was here to get the update. It certainly brings a lot of thoughts into my mind. My own focus in work has to do with values that become embedded throughout the research process. And of course, this has an intrinsic link to values because it's an ethically focused study. So a lot of questions pop into my mind, but I don't want to put Dr. Ho on the spot I would rather just say, obviously, this is a very rich area. I'd be very interested to see the connections that are made, not just to the health sciences literature in terms of maybe what's been done, but to some of the broader literature in terms of, actual just, I guess, philosophical approaches to hard questions like this, where maybe there isn't a right or wrong answer that's immediately apparent. It sort of depends how people are perceiving the ethical consequences of certain errors and so on. I'd like to explore or know through this project how maybe there was variation in terms of how patients viewed the ethical consequences of different errors that could be made here. My understanding in terms of business, for example, there's lots of online conundrums that are similar in some respects, where, online forums are basically saying, if you want to access this online service, the deal is that we're going to collect your data. And there's no sort of consent process there other than, a disclosure that the data will in fact be collected if you proceed with accessing the service. And of course, that may or may not be appropriate depending on the specific situation where you're doing a cluster trial. And for me, it might raise issues like how easy would it be for the patient to decline the service? If it was an emergency service, you might be in a different scenario than if it was a non-emergency service. But these are just thoughts that pop into my mind off the cuff, and you're certainly better equipped to address the questions than me, and it's just very, very interesting work. So I'm very thrilled to hear that it's going to go on.
Thank you so much, Stephanie. Actually, I think that these are some really interesting questions, and while you were talking as well, I was thinking. I mentioned earlier that we're hoping to have focus groups in Vancouver, Kamloops, Kelowna, because I also have been thinking about what the difference might be in terms of thinking about research and service access in the urban areas in comparison to in more rural areas, when maybe many people have actually less access to services in the first place, and they may also have less access to various types of research opportunities as well. And so would they think about consent in different kinds of ways? And so that also got me to think about before, and when Kip and I were talking about this together, when I was living in Minnesota before, and having to access healthcare services in the university health centers, it's almost like a default thing that they will always ask you whether you would consent to have your images or your medical information to be accessed by trainees. And it was never very clear in terms of what it would mean if you say no. And there are people in the bioethics and research ethics community that have been arguing, not a lot of them, but some of them have been arguing that actually, especially for people who are receiving care in teaching hospitals, research hospitals, that the default should be that they are also consenting to their data being used, maybe de-identified data in some of those cases, but that they should be automatically consenting or automatically allowing their information, their data to be used for teaching and research purposes. So that may bring us back to questions about public trust as well. Especially when we may be talking about certain populations that have less access to services already. And what would it mean if we say that you must consent, or the consent is already implied if you are part of a hospital, if you're seeking any kind of service from a hospital already. So definitely something that we want to keep in mind. Mm-hmm.
Stephanie, thank you for raising those points, and Anita for your sage reply so on the spot so quickly. I wonder if this is an opportunity, Pia, with the shift in the discussion. Would you like to have any further comment on this particular issue?
Not right at the moment.
Okay. I wonder if we can go back to the question that Anita shared about people's thoughts in whether to keep this project focused on primarily a single patient population, in this case, those living with spinal cord injury, versus what the advantages or limitations might be of expanding it to multiple patient populations. Linda, I know that this is something that has crossed the projects as they were formulated in KTIS, in the Knowledge Translation Implementation Science Methods Cluster. Would you like to add any insight on the relative advantages, disadvantages of single patient population versus multiple?
Right. Oftentimes when these sort of decisions are being made, I think it largely depends on what is available in terms of resources and support and the timeline that's available. So ideally, of course, you want to have, as a diverse a population as possible, and such that you can collect information data that is representative, or at least, giving a voice to, a broad population, and the results will be, likely more applicable, to the population in which, people have contributed data to. But, in reality, when the resource is limited and when, there is a tight timeline for a project to turn around, I don't think it's unreasonable, especially for, projects that are at a novel research question at the early stage of, understanding, the area and collecting information, that you start with one specific population. So I think, in the decision of, doing the project with the spinal cord injury population as a start versus expand it to other populations, I think it largely depends on some of the decisions that's made, between the investigators and what resources that, is accessible for the project to happen. So, it's difficult for me to comment on whether it's a good thing or not a good thing, but I don't think there's wrong decisions here, as long as you can justify the process, and that, every step is, a step for something else that you can build on. So, if this project starts with one population and it expands to, the framework is, apply and validated in a different population later on, I think that's a step toward the right direction.
Thank you, Linda. Interesting. We had a discussion about that, this very topic this morning, not in regards to non-consent in CRTs, but the difference, the overlap, and yet the uniquenesses between diversity versus representation. In that, if there is a greater percentage participation by a particular population or subpopulation, that is, that might not be as much of an issue if that is representative of the population at large. So, Anita, I wonder, as we've got about another 4 or 5 minutes until Hui is able to join us. Would you like to respond to that diversity versus representative issue?
Well, because I think that if we want a framework to apply to different types of CRTs, and I think that it would be best, as like Linda was mentioning, that if we could have a bit more diverse, and that can be applicable to different trials, that would be better, because the REBs will most likely be reviewing trials from different populations. I'm guessing that as Linda was saying too, the real-world recruitment also of our patient representatives to be part of this may also given the time constraint, may also be a little bit more limited at the beginning. So I'm foreseeing, and I need to talk to Kip a bit more and the other team members as well. I'm foreseeing that the starting point will be the ICORD patients, but at the same time, we will also look at some of our other research partners in other different projects that we have had as well. And I'll talk to Pia more in trying to see whether there might be other researchers. And so there have been some research members or researchers who have been wanting to be part of this, but they thought, oh, the areas of conditions that we're thinking about are quite different from what the researchers are interested in. But I think what I'm going to do is to go back to some of them and ask, okay, maybe you don't have time to be part of this project, but do you think some of your patient populations, people you have engaged with before, might be interested to be patient representatives as well, so that we can at least get their perspective, even if these researchers themselves may not be able to participate.
So yeah, Anita, that's an excellent idea, and I'm happy to assist you in that. So let's maybe touch base offline. Are there any further comments or questions for Anita? I see that Wee has joined us, so I just give the opportunity for last-minute questions or comments for Anita.
It's Pia here. I think, yeah, Anita, what you've just mentioned is really, that's a great idea. And we can chat about it more.
Okay, thank you.
Thank you. Anita, we really appreciate your time this afternoon. We appreciate you submitting this proposal and sharing it with our audience. As I said, that for those, we often find that there's more people who are able to view the webinars asynchronously when they have time in their workday. So if there are any additional questions, you see on the slide in front of you Anita's email address. And if you have any questions in regards to connection or need any help, please feel free to contact myself. At the final slide of today will be both Hubert and my email for contact. So thank you again, Anita, and we're now going to pass the mic over to Wee about his project, Improving the Efficiency and Robustness of Statistical Inference for Patient-Oriented Treatment Effect in Real-World Clinical Trials. So Wee, over to you.
Yep. Yeah, thank you, Alison, for the introduction. Alison, and thank you, everyone, for giving us the opportunity to present our research proposal. So Alison mentioned our title. I will now repeat it. So our team members include the following person. Includes Professor Joanne Hu, who is a professor of statistics at the Simon Fraser University. And I myself, I'm also a faculty member at Simon Fraser University, Faculty of Health Sciences, and also a research scientist at Arthritis Research Canada. And also our team members include Professor Karim and Professor Wang, who are both professors at the University of British Columbia School of Population and Public Health Sciences. And we have our research collaborators, Dr. Diane Lacal, who is a professor from School of Medicine from UBC, who will provide expertise in the knowledge in the clinical background, and who are also knowledge users and the decision makers. And Professor Linda Lee, who is a chair professor at UBC, and who is an expert in knowledge translation. And and we have patient partners, Lian Gaoka, and other potential patient partners. Next slide, please. Yeah, thank you. So we know that the real-world clinical trials are important important for patients because they provide information about the treatment effect in the real-world settings, and this is especially useful when we are evaluating complex interventions such as behavioral interventions. And at the same time, these RWCTs can also raise important challenges. So they can include, for example, the limited sample size because of the low compliance rate in the real data setting, as compared to the clinical trials in well-controlled conditions. And these RWCTs, they often have multifaceted interventions for chronic disease such as arthritis. So the consequence is that the endpoints often involve multiple outcomes. And it is likely there are small to moderate effect size on some instead of all outcome measures. And also these RWCTs, there are in these RWCTs, there are often difficulty in learning patient-oriented treatment effect. So when the compliance rates are low, the standard analysis is called the intention to treat analysis. So it estimates the so-called program effectiveness. It takes into account the compliance behavior. It does not use those information, and the program effective, the size of the program effectiveness actually depends on the compliance behavior of every patient. So it is useful for policymakers to say, suppose the treatment was applied to the population, what is the likely the benefit we received as a population, given that there is the compliance rate can be low. However, as a patient, such a program effectiveness may not be that relevant because a patient may wonder why the treatment effect should depend on other patients' compliance behavior. So they may be more interested in intervention efficacy, and that informs what to expect when this specific patient actually complies with the treatment. So currently, the so-called complier average causal effect, abbreviated as a CASE, has become increasingly popular to patients and their care providers to inform such a patient-oriented treatment effect. And statistically speaking, the CASE is more sophisticated than the intention to treat analysis. So all these challenges demand efficient and robust statistical methods for estimating those patient-oriented treatment effects. Yeah, next slide, please. Yeah. So here I will describe a case trial to put the proposal into the context. So this is a real-world clinical trial on the effectiveness of a behavior intervention called the Arthritis Health Journal, abbreviated as AHJ. So AHJ is an online tool that enables rheumatoid arthritis patients to monitor their symptoms and disease activity. So this is a clinical trial with 2 arms. With first arm called the immediate group that receive the AHJ immediately. And the second group called the delayed group, where the patients receive the AHJ in a later period. So in this trial, there are important number of participants did not use the intervention or use it seldomly when they were assigned to receive the AHJ treatment. So there is a significant amount of treatment non-compliance, and also we have a total of 6 health outcomes measures that were collected, measuring different aspects of managing the disease, symptoms, and the interactions with the care providers and knowledge, etc. So the question here is, how do we most efficiently evaluate the complier average causal effect to inform the patient-oriented treatment effects on these 6 health outcome measures. Yeah, any questions? If no, next slide, please. Yeah, so here is our research objectives in this proposal. So first objective is to develop and validate the most powerful tests for intervention efficacy in RWCTs with multiple outcomes. So here, when we mention the intervention efficacy, we use the complier average causal effect to estimate the intervention efficacy. And the second objective is to develop robust non-parametric procedures and efficient tests for estimating the case in RWCT with multiple outcomes. And in the third objective, we will reanalyze the AHJ study to demonstrate the benefits and the uses of the new procedures. So we, before submitting the proposal, we conducted a preliminary study that focused on the period 1 of the AHJ study. And this preliminary finding demonstrates some very promising results. So what we find is that using the new procedure proposed in this proposal, we can obtain more precise efficacy estimates. Those estimates, they all point to the beneficial efficacy estimates for all 6 outcomes. And in contrast, the conventional efficacy estimates have a larger variability to the extent that the efficacy estimates of the 2 out of 6 outcomes actually point to the direction of the harmful treatment effects. And also our estimates are more precise, meaning that they have a smaller standard error and narrower confidence intervals. And we also conducted simulation studies. So using the settings that are similar to the practical RWCTs. So specifically, we considered the moderate effect size and the low compliance rate. And the simulation studies shows there is potentially a significant amount of increase in test power. The test power can increase from less than 20% using the conventional method, and increase to the 70%, to the larger than 70% with the proposed new procedure, and with at the same level of type 1 error rate of 5%. So these are the potential increase in the power to detect the treatment effect is significant, meaning that we can significantly reduce the required sample size in order to achieve the same power to detect the treatment effect using the new procedure. So the efficiency of the new procedure is larger. And based on these promising results from the preliminary study, we in this research proposal, we propose to extend the method to a wider range of types of RWCTs and to analyze the entire AHJ study. And finally, we aim to disseminate the set of the developed methods and software packages implementing these methods so that other people can use them. Yeah, so that's conclude my presentation. Questions and comments? Thank you very much.
So thank you so much, Wei, for sharing the details of your project proposal. I'd like to open up now the opportunity for participants in real time to share their questions and comments to Wei. Maybe while we're waiting for some questions and comments, Hubert, from your perspective, is this kind of a situation something that you commonly run into?
Well, I think it's pretty common. Again, I think the uniqueness of this project is looking at multiple types of outcome measures all at the same time. Now, we have another project in the cluster that looks at it from a different perspective. So the one that's being led by Joel Singer and Nick Bonsbach, where they're trying to find the relative sort of weights of different outcomes in terms of the patient values, how patients value them. But I think this is a little bit different. It's not so much about weighting these outcomes, but still trying to leverage information from one outcome to another one. Is that how sort of a fair summary of that, Wei?
Yeah, I think your summary is quite on the point. I think the two projects are different in how they tackle the multiple outcome issues, and also, so as you mentioned, the first one is the previous one is using the weighting, and that requires additional survey data to know which how do you put the weight, and this approach is different, slightly different. I think it's somewhat different. We don't require that additional data, and also I think this project focusing on the case estimate, to estimate the intervention efficacy. Yeah.
Thank you. I wonder from the perspective of others online, either Linda or Stephanie, do you have any comments or questions for Wei?
Could we back up and just look at the previous slide?
Absolutely. The objectives one?
Yes, exactly. It's
okay.
It's one of those studies. This is complicated stuff, right? So it takes quite a bit of time to interpret everything, and I don't know. This raises an issue that I think actually at at the FOR conference, Hubert, you were mentioning, there's this question of how to involve patients in the really deeply mathematical parts of this type of research. Am I right? And
that's right.
The thing that comes to my mind is, and I think Dr. Ho is still on the line because you come from ethics, you're sure to be familiar with, the concept of inductive risk, right? And so the question is, I've always wondered, throughout this process where there is, we're trying different mathematical procedures and so on, how does it change the risk of potential errors in one direction or another direction? And, would patients have any interest in understanding how the methods change the risk of error and whether those errors have and what consequences they would have in the real world downstream?
So it's a question, I think actually Anita's no longer online at this moment. I think she had to leave. Let me just check.
Oh, okay.
Yeah, she did have to. So
it's possible that I'm raising potentially an interest that's relatively esoteric. I guess that I could raise it in question form, which is in a simple way, from a mathematical point of view, the new methods that you're proposing here, what would be the effect on the risk of error? Or is it even possible to explain?
So this is a question for me, right?
Yeah.
Yeah, that's right. So when we do the clinical trial study, we typically have two types of errors. One is called the type 1 error rate, right? Which means that if there's no treatment effect, but you give a false positive.
Yes.
Yeah. So both the new procedure and the old procedure, the standard procedure, they all have the same type 1 error rate of 5%. So the false positive rate, they all controlled to be no more than 5%. Yeah.
Okay, so that would be the same in this strategy. That's not being changed.
That has not been changed. Both tests have the same amount of the false positive rate. Yeah, but the difference is that the false negative rate of the new procedures is significantly reduced.
Right.
So it's more powerful to detect the effective treatment. So this is useful because in many trials, the treatment effect is typically moderate effect size on a few outcomes, right? So no significant, very large treatment effect on any single outcome.
Right.
So what happened is that what this procedure can help most is that if you have say moderate effect size across several outcomes, and you analyze them separately, each one is a small effect, but they have a cumulative larger effect, and then this procedure can be more powerful by combining information from across those outcomes to help you to detect the treatment effect.
Okay.
So I think that is the rationale of how this procedure can increase the power for you to detect treatment effect when you have a multiple outcome.
Okay. Yeah, the concept that I was referring to, that where there's some ethical discussion, it has to do with just from the point of view of patients, which errors they consider to be more serious, accidentally, like a type 1 versus a type 2, which,
that's right.
it's two different types of error, and so for patients, which one do they consider to be the more serious error? But I guess I understand now that you're saying the strategy that you're proposing actually will not change, relatively speaking, either rate of error. They both will stay the same.
No, actually, actually the false positive rate does not change.
Yeah.
But
the false
negative rate is reduced.
It's reduced. Oh, okay.
Yeah.
So it's actually advantageous across the board then.
I did not quite get that.
So it's a total improvement in terms
yes,
of error.
It is dominant. It's dominant.
Yeah. Okay. It's dominant. Okay. Great. That's a very interesting because sometimes methods one can go up and the other goes down and vice versa.
Yeah, that's right. I mean this. Our preliminary shows that this is in general is a preferred procedure. I mean, of course, we have a further work. This is a promising result. We want to further increase the robustness of the method. Yeah.
Right. Okay.
Yeah.
Thank you.
Sure. Thanks for the comment.
Yeah, thank you for a great question, and for your answers and the discussion here. From the perspective of the methods clusters, it's phenomenal to see. It's so exciting to see how many of the projects are leveraging existing data sets. And building on projects that have already started, because as many of our participants can probably acknowledge, the time periods for a research project to be proposed and then be undertaken and then be analyzed and then to be shared is can be a lengthy period of time. So based on the time frames of the support unit, it's exciting to see that we're able to move much more quickly with these methods cluster projects because of building on existing projects and on existing data. So this is just one of many examples in that case. I note that we've only got a few minutes left, and I wondered if there was anyone else online who has a question or a comment before we go to closing remarks from Hubert. Okay, hearing none at this point, maybe we can go to the final slide. So I want to thank again both Anita and Wei for their presentations today. A lot of work goes into pulling these teams together and these project proposals together, and the willingness to share them so as to be able to build the community of methodologists is exactly what we're hoping to inspire within the support unit. And I can't thank you enough for doing so today. If you have questions about these projects, being involved in the methods clusters, then here are our email addresses. Please reach out to either Hubert or myself. And Hubert, do you have any parting comments?
Not much. I want to reiterate my thanks for you guys participating in this. And I think in addition to reaching out to either myself or Allison, I think you guys are also welcome to reach out to these project leads as well if you want to be involved. Right?
Most definitely. We didn't have a slide with Wei's email address, but if you're watching this in your own time, you're watching the recording in your own time, feel free to email me and Wei, is that okay if I provide your email address to people who have questions?
Yeah, absolutely. Feel free to do so. Thank you.
Thank you so much. We'll try not to, inundate you with questions, but it's such an exciting and novel area that's applicable across so many projects. So thank you. So without further ado then, I think we'll close off for today, and thank you all for those who have participated in real time and viewing the recording. Thank you.
Thank you, Allison. Thanks, everyone.
Yeah, thank you.